I think we'd like to really thank Jason, too, for sharing his story. It's a very brave thing, and you just never know who you're going to help. You might hit one person who watches it and is motivated to get help. So joining us now to talk more about the SBIRT program is Brandy Leonard, who's a nurse, clinical RN, a safe nurse at the GBMC Emergency Department. Thank you so much for being here. And Ron, who is a certified peer recovery specialist. You are such an integral part of helping people with whatever addiction they may be facing. So thank you both for being here. We tied this into, our discussion about mental health because so often people are experiencing some mental health issue and they may turn to alcohol, or they may turn to opioids, or they may turn to heroin, or what have you. And I'm sure you've seen it all, right? And oftentimes the first place for people in crisis to go when they're in some sort of crisis with whatever they're addicted to is to come to the ER. Mm-hmm. So let's talk about what SBIRT stands for and what exactly you do.
Okay. So the SBIRT program is our peer recovery program at GBMC. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. In our SBIRT program, we have 4 peer recovery coaches and 1 OSOP coach, which is actually Ron. So our coaches meet the patients where they are in the emergency room, whether they came in for a medical diagnosis or a substance abuse diagnosis. They get screened as soon as they come into the emergency room by the nurses. And once they're screened, and if they screen positive, then one of our coaches will meet them in their room and have a discussion with them.
And let's talk about why the coaches are so effective and why you as a peer specialist you can reach people that oftentimes maybe a clinician cannot.
Well, yeah, in the emergency room, they're only interested in 2 things, your pain level and how fast they can take care of you and get you out. As a peer, I'm interested in what brought you in there for the substance use part. Whether it be trauma, whether it be PTSD, whether it be homelessness, death in the family, anything can trigger someone to self-medicate. And so they can relate to me because I'm someone who's in long-term recovery from substance use disorder. So when I tell them that, they're like, oh, okay, you're not a doctor. And I'm like, no, I'm just like you. I was homeless at one time, and I used to use heroin and cocaine just like you. And once you say that, you can see their walls come down, and they're willing to accept the help and listen to you at least about the resources that we have for them to help them.
So obviously the first order of business is the screening, right? Mm-hmm. I mean, it's to recognize when somebody comes in the ER maybe for a broken arm, let's say, what the real issue might be. Let's say they are an alcoholic or they've been drinking and that's how they fell and broke their arm. So you have been trained to look for signs?
Yes. So the ER nurses are all trained in something called the Audit Sea Screening. All patients, whether they come in for medical or a substance abuse complaint, get this screening. The screening may ask questions like how many drinks per day do you drink, how big are the drinks that you drink, how often a week are you drinking, and then how often a month are you drinking. And depending on their answers, they will get a score, and depending on how high that score is, they'll get referred to our peer recovery coaches automatically in our system. And then we have drug abuse questions where we do ask patients, have they used any illegal drugs or are they misusing their prescription medications at home? And then they will also screen positive.
It really strikes me at how you're helping people so much because years and years ago, I'm sure, you would go to the ER with an issue and the doctors there would just fix whatever it was, the broken arm, and no one would question why you fell or what else is happening in your life. So you're really this kind of wonderful safety net that comes in and recognizes some things that may be really, really, really difficult to deal with. But then the patient, if I'm understanding correctly, moves kind of from you to the coaches. Is that right?
Correct.
Yes. So they'll screen positive with the nurses, and then once they do, they'll be referred to the coaches. And once they're medically cleared, whether the nurse says it's a good time to go ahead and talk to them, that's when the peer recovery coaches will take over.
Okay, so that can be an all-encompassing, I mean, this can take a long time and quite a process because, yeah?
Yes.
So you're taking these individuals and you're saying, okay, where can we meet you where you are? What is the next step? How far do you follow them? And what would be some of the next steps?
So we have peers that are mainly for the emergency room that follow them as far as phone call follow-ups. I am what is the opioid overdose survivors outreach program coach, and what that is someone who came in for an overdose and survived. They would be followed up by myself for up to 90 days outside in the community. But GBMC's number of overdoses were smaller than some of the other hospitals, so we expanded it to alcohol and high utilizers. And these people I follow up with, and when I say follow up, I might go to court with them. I'll meet them for coffee. I'll meet them at whatever support group that they're finding on the outside, whether it be meetings or church or wherever. That's where I've developed that relationship with the patient. So when they are ready to say, hey, Ron, I'm ready to go to treatment, or I think I need to further my recovery, I'm there to help.
Is it fair to say that they have to be ready?
Absolutely. Yes.
I would imagine that your job, and maybe your job as well, can be incredibly frustrating when you see people who, addiction's such a difficult thing, and there's so much backsliding, and patients, I mean, you must really, when I'm thinking of patients, like not patients that you see, but patients you have to have internally to work with people.
Yes.
We have a lot of frequent flyers that we have in the emergency room, and it's hard as the nursing side of it not to get frustrated, but it's really cool when they keep coming in and then eventually they're ready, because we have had several like that. All of a sudden they're ready and then they flourish, and you can see them through that journey of not being ready, and then you slowly break down that wall, and the peer recovery specialists do that. They start from the beginning, and then they break down each of the walls, and then eventually we get them into treatment, and they just fly, and it's really cool to see.
That must be incredible. Yeah. Do you follow the success stories? Do they come back to you?
Yes, we do.
Jason was one of them. We have a couple other that we follow. Some we follow up and have lunch with. Yeah. We have others that just call to check in.
And say, hey, I'm still doing fine. And there's some, like I said, I'm a person in long-term recovery, so there's some I'll see in the community at my support group that I go to, and I'm like, hey, and they're like, hey, I'm still here, and I'm like, I'm glad, good to see you, you know.
And it kind of builds a bigger support family for them, too.
Do you find that more and more people are feeling freer to talk about what their issues are? Does it help them in their recovery to talk about it, to help others? I'm sure it's helping you, Ron.
Yes, absolutely.
And that's a big step to recovery, too, is to reach out and help others.
Yes.
We were talking earlier, obviously, with Dr. Ferentz about mental health, and I know that GBMC is trying to sort of find that correlation, right? Working to really identify what could be the underlying reason for drinking or reason for taking drugs. Is there something that you're seeing more and more of lately, or have things changed over time as far as the types of people coming in or the types of issues that they have?
I think we're finding a big correlation with like the dual diagnosis patients, which are patients that come in who are coming in for a substance abuse disorder, but they're in turn just self-medicating their depression or their anxiety or their PTSD. And I feel like we get a big correlation of that, especially in the emergency room, because they're not following up with their primary care physician or seeking help outside of the emergency room, and that's all they know to come to. So they come to us, and then they in turn get a mental health diagnosis, and where we can get them somewhere inpatient mental health and hopefully follow up with them on their substance use after they treat what's really going on.
As a peer counselor and to speak for some of the coaches as well, do you find that people are quicker to accept their addiction as opposed to their possible mental illness, or are they open to looking at what the underlying cause may be, or can you treat one without treating the other?
Well, as coaches, we like to say which came first, the chicken or the egg. Like which one are they? Mental health, and we have a good psychiatrist. Is that what you say? Psychiatrist team that we also work hand in hand with, and we'll talk to them and be like, okay, is this patient more mental health or are they more substance use? Are they having mental health issues because of their substance use, or are they using substances because of their mental health issues? And we work together with the psychiatrist to figure that out. But most patients know that they're self-medicating. They know that they have mental health issues and that they're self-medicating. And what they'll say is, I want to go get my mental health straight first, and then I can work on the substance use.
Is that how it usually works? Oh, I would think the substance abuse would come first.
So normally, it's kind of cool. We have a program in the emergency room where we can actually start patients on a bridge program. We call it MAT, which is medication-assisted treatment. So if patients are coming in for opioid abuse, we can start them on buprenorphine. That would link them to get to a clinic to eventually come off of it, but we have done that for our mental health patients to kind of get them through their mental health diagnosis and their mental health stay, and then later we can follow up with them and make sure they're continuing that and continuing like their substance abuse treatment. So we do offer that in the emergency room as well. There's a specific criteria that they have to fall in, but it is something that we offer.
So now obviously we're in the holiday season, and I think over the years everyone's heard that this can be a very stressful time for people, and it's proven that it can exacerbate depression or anxiety or substance abuse. Do you say to yourselves, okay, we're going to get a lot of people this month, or do you expect that to happen? Is that because that's been what the past has shown?
The past has shown that. I've been in the emergency room for 5 years now, and we always have an influx of mental health crisis complaints, and we have in turn the increase of screenings of positives on our expert screen. So we do see a higher correlation during the holidays, maybe not necessarily on the actual day, but most of the time after people have seen their family and they're kind of coming off of that drinking binge or using binge.
Are you seeing more young people? Are you seeing older people? Is there a change in the type of population, or does it just run the gamut? I mean, it's just anyone can be affected.
Well, anyone can be affected. Well, being as GBMC is close to Towson
Right.
University, we see a lot of young intoxicated people. But they're 18 and 20, they're just out having fun. More of the substance abuse part are middle-aged people, a lot of middle-aged.
And we're seeing a higher increase in the older adults lately too as well. And that's mostly with like prescription medications and stuff like that, using them along with alcohol.
Okay, even with all that now that, the public service announcements about opioids and the dangers of prescription meds, it's still, we haven't turned that corner yet from your perspective.
Not yet. And then there's a lot of times when people are abusing their bridge medications as well, like their Suboxone or buprenorphine.
We see a lot of people that have felt non-compliant with their mental health medication turn to substance use. And once they get compliant with their mental health medication, the substance use, usually they can take care of itself. But a lot of, especially now, and I think it's not more the holidays, I think it's more the weather. A lot of the mental health and substance use community are homeless, and it's cold. So if I'm hungry and cold, I'm going to the emergency room. At least I know for the night I'll have a warm bed and something to eat, and maybe get some help. So
you know firsthand too. I mean, and you can probably make a comment on the broader issues of, are there resources available? I mean, you get people to a place where they might be stable and willing, but then do you struggle to still find them once they get back out into the community and you kind of release them, but are following them? Are there resources for them? Do we have enough?
So as a coach, the hardest part is to get someone linked while they're still in the emergency room. Because we find that once they leave the emergency room, it's hard to catch back up with them. Once they're gone, we always say we have the smallest window to get them into treatment, because as soon as they leave the emergency room, then they're going to resort back to old behaviors. They're going to go back to what they know. Okay, I was supposed to go to treatment, but I'd rather go get what I need right now instead of that. And then we've lost them. So our biggest thing is trying to get them linked to treatment when they say they're ready to go, get them there. And that's what we're...
We have a population that might not necessarily be insured.
Yeah.
So it's working with social work and all kind of team members to figure out what we can get them to apply for, so that way in their time in the emergency room we can get them linked quickly and get them into recovery housing, so that way that window doesn't disappear.
You talk about the frequent flyers, the people who, fall off the wagon again. I'm sure, and I hope you don't mind me asking you this, but I'm sure that they've said to you, Ron, how did you do it?
Yeah.
How are you doing it? They're finding it so hard they can't, and they probably are disappointed in themselves.
Yes. I mean, well, shame and guilt and embarrassment kept me out there using longer than I would have liked to. Well, they ask, well, how did you do it? And I tell them my story, which is I just got tired. I realized that I did not have a drug problem. I had a me problem. Drugs were just my solutions to the problem. Today, I just have new solutions to the same problems. I just have better ways of dealing with them. I have a network of people that I can talk to. I had to, dig inside of myself and say, hey, Ron, it's okay to tell another man how you're feeling. That's a lot of things, it's okay to do that. That doesn't make you, less of a man. That if anything, that makes you more of a man, because you want to better yourself, and it doesn't matter who's helping you. So, and a lot of people, I call it male puffery. That's what some, they especially men, don't want to get help. They want to deal with it on their own, and it's hard to ask another man for help. And I say, well, you've started the process. You're asking me, how can you get better? So you're already starting the process. How did I do it? And then from there, I'll tell them step by step. Well, first you have to break the cycle. You have to get away from the drugs to clear your mind. So that would be going into treatment, some type of inpatient treatment, if anything, just to get you away from where you were at, and to give you a fresh start. And then while you're in there, work on yourself. Work on learning who you are as a person and what you want to be. And that's where I started.
That's wonderful. Finally, I just wanted to ask, this is the coaching charges to the patient, or is this sort of?
No, so they get charged whatever the emergency room charge is, but they don't get a specific thing for our services in Espert. It's free for the patients. It's strictly just to help.
Sounds like a lifesaver. Thank you both so much for joining us and sharing what's going on with Espert and what's going on at GBMC to help, particularly during this time, which can be difficult for a lot of people. Best of luck.
Thank you.
Thank you so
Thank you.
much. And thank you all so much for being with us today, and I hope we all learned a little bit of something, and we feel comfortable talking about our health and our mental health. It's okay. Everybody goes through things, and there's help available. So I think that's really the takeaway. And have a great holiday season, and thank you so much.